Hey everybody, welcome back. Hope everybody had a good weekend. My name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And this is going to be the next in a series of sort of long play lectures that I'm going to put up on YouTube. And really the goal of these is to give the residents, to give the fellows, any faculty radiologists as well, I suppose, that wants to use them, but to give the trainees something, some more resources they can have at home. I know things are tough right now. There are residents and fellows potentially getting sent home or furloughed or, potentially even in quarantine. And so at any rate, want to do what I can, put as much educational content out there as possible. And at any rate, this talk is going to be on non-traumatic temporal bone emergencies. So enjoy. Just a couple disclosures here. First of all, I don't actually have any financial disclosures, but I do want to make sure to be very upfront and make sure that it's abundantly clear that all of the educational content found within this presentation has been completely de-identified in order to protect patient privacy. There are a couple folks I'd like to thank. First and foremost, Rachel Seltman, one of my former residents and fellows, who was very kind enough to share some really great cases with me. Temporal bone cases over her years in training at IU that I've kind of collected. And so several of these are hers, and some of them came from a presentation that we did as an educational exhibit at ASHNR a few years back. And then also Rick Harnsberger, someone who's been a great mentor to me and a great teacher as well. And so Rick was kind enough to, over the years, share some of the graphics that you'll see in this presentation. So thank you, Rick, again for everything. Okay, well, so again, this is non-traumatic temporal bone emergencies. And so this is a really diverse spectrum of emergent disease processes that can involve the temporal bone. And so the relative frequency that you, as a radiologist, will encounter these truly depends a lot on your practice setting. So it depends on if you're seeing mainly adults or if you're seeing mainly peds or if you're getting sort of a healthy mix between the two. It also depends on if you're seeing mainly folks that are getting referred to you from a primary care setting or whether you're seeing tertiary or quaternary care patients. That's also going to change the relative frequency in which you see these things. And then also population health variables are quite important. Depending on just the background, quote unquote, healthiness of your patient population really sort of drives the needle on some of these diagnoses. But the focus of this talk is going to be on what I think to be common temporal bone emergencies that I think are seen fairly widely across all care centers. So these are things that you should know about, you should be aware of, you should know how to interpret the studies, and give the referring doctors the information that they need for their next steps in management. So as we approach temporal bone emergencies, and this is just a graph. It's not anything that has a strong numeric value. This is sort of the Gestalt graph, but this is sort of how I look at things, how things come to me at my current practice of temporal bone emergencies. And there's a fairly even split between trauma and infection. And less frequently do we see vascular issues. And then there's something that I'll talk about at the end of this presentation that I like to refer to as contextual temporal bone emergencies. And we'll cover those more, like I said, toward the end of this talk. Now, I'm not going to focus on trauma, okay? Talked just a little bit about trauma in one of the prior lectures that I gave you guys on conductive hearing loss. We're not going to talk about it here. That could be a topic in and of itself. We're going to focus on these other etiologies. So, first up, we're going to focus on infectious temporal bone emergencies, and this is going to make up the bulk of my talk. So I like to break it up into different subsites of the temporal bone that are involved. Okay, so first we're going to start with the middle mastoid, because that's just where we see probably the bulk of the infectious emergencies involving. And the first topic under that category is acute coalescent otomastoiditis. And this is due to an acute infection involving the middle ear or the mastoid. And sort of the end game is that you get rarefaction and resorption of the bony septi within the mastoid itself, as well as along the outer table of the cortex or potentially the inner table of the cortex. Fortunately, this is an uncommon complication of acute otitis media. We don't see it a lot, but it's something that's critically important and something that you need to know about. So what's the pathophysiology behind this? Well, you get a mastoid infection, and that leads to local hyperemia because of this purulence going on in the otomastoid. And in addition to having this hyperemia, you also end up getting some underlying venous stasis and some osteoclastic resorption of the bone, particularly those mastoid septi and the cortices. And the real critical thing here is that suppurative infection, because that sort of acts as a catalyst for this resorption of bone. And it's thought to occur because, A, we've sort of trapped all of that pus within that enclosed environment of the mastoid and middle ear. So as that starts to fill up the space of a fixed volume, that's going to drive your pressures up. And also, you're operating in a locally acidotic state. So those two things, the increased pressure, the decreased pH, that's going to lead to bone ischemia, and that's going to sort of drive osteoclastic resorption. So it's not quite the same thing as osteomyelitis. There's a technical difference, but I'm a lumper. I'm not a splitter. I sort of put these two in the same camp because for all intents and purposes, they sort of mean the same thing in the end. This sort of ups you to being a potentially surgical case and somebody who's going to need to get hit hard with antibiotics. So again, I want to stress, you're dealing with something whenever you see this rarefaction of bone, the bone getting dissolved, the bone getting eroded, you're dealing with something that, yes, of course, they're going to hit them hard with antibiotics, oftentimes, not always, but oftentimes IV antibiotics. But these may now be surgical patients depending on the extent, because what we're trying to do is mitigate risk of infectious complications. So how do we approach these in terms of an imaging workup? CT is really our frontline player. You know, we talked about this in the temporal bone anatomy talk. We talked about this in the conductive hearing loss. CT is really the first modality that you turn to. And that's because it provides superior bone detail compared with MRI. So what are we looking for on CT? Well, the first thing that you want to look for is a pacification of the middle ear and the mastoid air cells. That in and of itself is a non-specific finding. We're currently operating in a climate where specificity, particularly with this COVID crisis, specificity is something that the imaging may not be able to drive strongly. And this is just another example where you need to know what does the imaging tell us in terms of sensitivity and specificity of disease. So when you see a pacification of the mastoid cells of the middle ear, that is not a specific finding to say that you have an acute infectious process going on. Lots of things can cause that. But how do we add specificity to that sensitive finding? And that is to look for the focal demineralization and destruction of the mastoid septi or the mastoid cortex. So right here, where that yellow arrow is pointing, we see this opacified area within the left mastoid tip, but look carefully within it. We're losing our internal septi. It's sort of forming this coalescent cavity. And right where that arrow tip is at, that inner table of the cortex is also focally dehiscent. So here's another case. Take a look at that left mastoid tip. You can see, wow, we sort of have this area that's becoming sort of hulled out. We're losing our mastoid septi. Compare that to the contralateral side where the red arrow is pointing. You can see all those internal septi. Those are getting sort of resorbed and eroded out due to this underlying acute coalescent otomastoiditis. Now take a look at the coronal recons. This is, again, another time where coronal recons are important because you can better assess the global extent of what's going on, and you can sort of figure out where you need to be looking for these complications. And as you can see here, we now have a trap door in the floor of the mastoid, right? It's resorbed that cortex or eroded that cortex out. Compare that to the contralateral side. You can see that nice, sharp, crisp cortex at the bottom of the mastoid tip. So as you can imagine, this would be a high risk for the infection to pus out going south along what attaches there? The sternocleidomastoid muscle. We'll talk more about Bezold abscesses in a minute, but this is a method or a manner in which they can form when you have that dehiscence of the cortex of the mastoid tip. Can you see acute coalescent otomastoiditis on MRI? And the answer is absolutely yes, but it's a little bit more challenging because we don't have the kind of bone resolution that we do with CT. So you need to be looking for the same findings, that mastoid septal or the cortical destruction or disruption. And here where that yellow arrow is pointing, you can sort of see that gray smudgy arrow within the mastoid. Out lateral where the fluid is all nice and T2 bright, we can still see those squiggly black septi within it. Where the yellow arrow is pointing, we're starting to lose those septi. That'd be a finding that would be much easier to be seen on CT, but you know what? Sometimes you don't always have that at your disposal. Sometimes they just come to you with the MRI first. This is what kind of stuff you need to look for. It can be subtle on MR. We see the bone erosions, the bone destruction better on CT. What does the fluid look like? Oftentimes it's a bit T1 intermediate. There should be some sort of fluid opacification going on, so there will be T2 bright areas within the mastoid and middle ear. Sometimes it looks more complicated like this, where it's sort of intermediate, getting more debris and gunk, as it were. And one of the things I think is helpful is to keep in mind it's not always as bright as the effusion. So this area where the yellow arrow is pointing, it's a little bit sort of more intermediate in terms of the T2 signal intensity. Look out laterally, you see that T2 bright fluid. Again, not a perfect finding, but those are all features that can help you sort of train your eyes where to be looking and then start looking for those septal erosions. The other thing that you'll see is a hypoenhancing pus pocket that's forming within that area of debris. And oftentimes that debris will have some underlying enhancement, but when you see it starting to loculate out, forming rim enhancement or a non-enhancing component within it, be concerned that you have a developing pus pocket, and that may eventually turn into an intramastoid abscess. If you use diffusion sequences, which I would recommend here, look for reduced diffusivity. That is a feature that tells you that you are trapping that separative infection in sort of a localized area. That's a tip-off that you're dealing with the formation of an abscess. Okay, so reduced diffusivity in the temporal bones is not always cholesteatoma. It is critical that you know the history of what's going on, because sometimes in the setting of infection, it can indicate an intramastoid abscess. But we've talked to, seems like I'm trashing MRI. I'm certainly not. MRI is extraordinarily valuable in assessing these patients because it is far superior to CT for looking for those complications. So these are complementary imaging modalities. So here's a patient with acute coalescent otomastoiditis. We have a T1 weighted axial pre-contrast image. We know it's pre-contrast. Okay, now let's talk about these complications, and there are a handful, and these are all critical things that you need to be aware of. The first is the subperiosteal abscess. So these subperiosteal abscesses form adjacent to areas where the mastoid cortex has been eroded or has become dehiscent. And this commonly occurs along the lateral wall. You can see right here where that yellow arrow is pointing. It's sort of, the bone is thinned out and it's focally dehiscent. And this is what sets you up for developing periauricular or preauricular abscesses or postauricular abscesses. So what does that look like? Give contrast. Give contrast on these. If you're concerned about infection in the temporal bone, I think it's totally appropriate to give contrast on a temporal bone CT as long as you're doing soft tissue reconstructions. You need to do the soft tissue reconstructions. I typically run those at about 2 millimeters of slice thickness rather than the 0.6s that we get for the bones, just for signal to noise purposes. But here's what this patient looked like when you gave contrast and is seen on the soft tissue recons. Now we can see nicely that there's this crescentic rim-enhancing fluid collection overlying that area of dehiscent mastoid cortex. And on MRI, same patient, we can see that there's thickened periosteum with all this inflammatory change around it. This is a patient with a subperiosteal abscess because their coalescent otomastoiditis has pussed out laterally. If you do diffusion sequences, you should see reduced diffusivity, confirming that this is an abscess. Another type of abscess that I hinted at before was a sternocleidomastoid, or so-called Bezold abscess, if you like to name things after people. And this occurs whenever you have mastoid erosion or dehiscence, typically along that undersurface of the mastoid tip, because that's where the sternocleidomastoid itself will attach. And what happens is you get pus that begins to wall off either within the muscle or sort of tracking along those fascial planes of the muscle. And so what you look for is a rim-enhancing fluid collection below the mastoid tip, sort of along the course of the sternocleidomastoid. So in this case, who was lent to me by Dr. Seltman, you can see this sort of multilocular rim-enhancing abscess that's below the skull base along the course of the sternocleidomastoid. This is a so-called Bezold or sternocleidomastoid abscess. As you can see, there's a lot of edema and phlegmon sort of tracking up along the skull as well. So MRI, again, quite sensitive for looking and defining the extent of the infection, and also offering that specificity of seeing things like abscesses a lot better than on CT. Critically, you have to keep in mind that if you can pus out laterally, you can also pus out medially, which means you can spread infection intracranially. So whenever we have that dehiscence of the mastoid, you also have to be looking at the brain. And so I not infrequently will recommend that they also do some whole brain imaging sequences on these patients who come in with a high index of suspicion for acute coalescent otomastoiditis, particularly if I see something on CT where it looks like the tegmen is dehiscent or something along the medial cortex is dehiscent, they absolutely need to get some whole brain imaging as well. So if you have a dehiscent area or bacteria translocating across the tegmen, that can get up into the temporal lobe because that sits right above it. If you have spread of infection across the medial mastoid cortex, it can get into the posterior fossa. And so what do you look for? Well, you look for complications like meningitis. So here in this case, we can see this pus pocket, this rim-enhancing intramastoid abscess. See how centrally that's non-enhancing? If you were to do a diffusion sequence, you'd see that that non-enhancing part would have reduced diffusivity, but this infection was aggressive and it spread upward, and you can see all this leptomeningeal enhancement from meningitis. You can also get cerebritis. So here was a patient that had left coalescent otomastoiditis, and look on this flare. Look at the lateral cerebellum. We can see that edema. If we give contrast, kind of have this wispy enhancement of kind of a good look for acute cerebritis as well. And then you can also get intracranial abscesses in the extraaxial space, along the epidural space, for instance. So here we have this axial T1 SPGR post-contrast sequence, and we have this very large lens-shaped rim-enhancing fluid collection on the inside of the calvarium. But look here, we also have a very similar thing happening extracranially. So this is sort of pussed out on both sides of the calvarium. So whenever you see a rim-enhancing fluid collection, ask for a diffusion. Take a look at the diffusion. Here's our diffusion trace, both that extraaxial intracranial epidural collection, as well as that subgaleal collection, show bright signal. Whenever you see that, look at your ADC map, and it's dark. So we can see here that we have both intracranial and extracranial abscesses. And then look at that ADC map. We have that area that's a little bit ADC bright that's extending anterior to it. That's an area that's more phlegmonous on the extracranial surface rather than representing additional abscess. So use those advanced sequences like your diffusion sequence, because that offers more sensitivity, but also gives you more specificity in differentiating where abscess and phlegmon are. Another important complication to keep in mind is that of sinus thrombosis. So you can get dural sinus thrombosis from the adjacent inflammation going on, or due to direct spread of infection. Both of those things can cause sinus thrombosis. Now, typically that's going to involve the sigmoid sinus just due to its proximity to the mastoid. And that clot can propagate. Once it forms within the sinus, it can propagate. You can have uphill thrombus where it sort of works its way back into the intracranial space, so it's sort of going against the flow. Or you can have downhill thrombus that propagates itself down below the skull. So here we can see in this patient, this coronal contrast enhanced CT, the yellow arrow is pointing to a filling defect within the sigmoid sinus, and the red arrow is pointing to this large extracranial subperiosteal rim enhancing abscess. I'm going to mag this image up, and what do you look for? Again, that yellow arrow is pointing at that filling defect within the dural sinus. Can we see it on MRI? Sure. MRI is actually kind of a nice sequence for looking for clot. And it depends a little bit on what sequences you're doing, but obviously you want to look for a filling defect, particularly on those SPGR post-contrast sequences. Those are highly sensitive for finding thrombus. Depending on the age of the blood products contained within the thrombus, you may get T1 and T2 shortening and prolongation effects. And so the signal intensity sort of varies depending on the age of blood products. But I think looking for areas that have asymmetric increased T1 or T2 or flare or diffusion signal intensity within the adjacent within the adjacent sinus, dural venous sinus, can be quite helpful. So in this case, we can see that we've got all that phlegmon and edema around the mastoid. We've got a pacified mastoid as well. And that flare sequence is showing increased signal intensity within the dural venous sinus compared to the other side where we see a maintained flow void. So that's at least telling us, hey, we've got some slow flow going on. Maybe it's thrombus. Use your other sequences to tease those out. Here's a patient showing you diffusion bright thrombus within the overlying dural venous sinus. The yellow arrow is pointing to it. If you look extracranially, you'll also see that there's a subperiosteal abscess component that's got reduced diffusivity as well. Same patient, take a look on the T1 SPGR. We see that eccentric filling defect within the sigmoid sinus, and then there's also this overlying subperiosteal abscess extracranially. The other thing that you can sometimes see is blooming artifact. So look at your GRE, look at your SWI, your SWAN, whatever sequences you're running. Yes, it can be prone to artifact in this area because it's at sort of a brain bone or even potentially an air bone interface with the aerated sinus or the aerated mastoid, but take a look at it. Sometimes you'll see blooming artifact within the clot itself, and that can be a helpful tip-off. And then if we can have sinus thrombosis, well, it can propagate downhill, and you can have jugular vein thrombosis as well. So that inflammation or that direct inoculation by infection can also thrombose the internal jugular vein. This is, as I said before, oftentimes propagation with that downhill thrombus. And what do we look for on imaging? We see a filling defect within the right internal jugular vein. This yellow arrow is pointing at it. See how dark that is centrally, but it also has this rind of enhancement around it, this kind of donut sign. And that's caused by engorgement of the vasa vasorum, those blood vessels within the wall of the jug itself that sort of supply the jug. Those sort of have static blood within them, or they even become engorged as you're trying to bypass that clot. That's a tip-off that you're dealing with thrombus. Centrally within the lumen of the vessel, a filling defect with avid enhancement of the wall from the engorged vasa vasorum. Take a look at the contralateral side where that teal arrow is pointing. You can see the normal opacification of the left internal jugular vein just for comparison. And then look around where that red arrow is pointing, all of that phlegmon. It's a bit tough to see on the SPGR sequence because it's not fat saturated, but you compare to the contralateral side, you see the myositis of the sternocleidomastoid and the adjacent muscles as well. All important tip-offs telling you about that inflammation and infection going on in the surrounding soft tissues. And again, look at your other sequences. Depending on the age of the blood products within the thrombus, it may drive up the signal intensity on multiple pulse sequences, as we talked about before. If you're doing MR venography, you're going to see loss of flow-related enhancement within that segment of the internal jugular vein. I truly prefer to do these post-contrast rather than relying on the time-of-flight MRV alone because I think that gives you more sensitivity and more specificity because you're actually delineating the filling defect rather than a manifestation of the flow. That being said, sometimes you can't give contrast, so you do have to be looking carefully on the time-of-flight MRV as well. All right, next we're going to turn our attention to the external auditory canal, and the big player here is going to be necrotizing otitis externa. So this goes by the really unfortunate term of malignant external otitis, and I try very, very hard to get my residents and fellows and colleagues to stop using this term because yes, it's malignant in the sense that it's really bad, but it sort of leaves this flavor of, oh, well, maybe we're talking about cancer. No, it has nothing to do with cancer, okay? I think the better term is just to refer to it as necrotizing otitis externa because that sort of knocks the confusion down a bit. So what is it? Well, this is an aggressive invasive infection of the external auditory canal. You can see it denoted here by this yellow arrow. We see all of that soft tissue thickening within the EAC. It's avidly enhancing, and then it's sort of extending out and laterally as well, and you can see all this phlegmon surrounding it where the red arrow is at, because this can actually spread into the surrounding soft tissues as well as cause osteomyelitis of the skull base. So we'll talk more about those things on the coming slides of where all you need to look. This is most commonly going to be due to Pseudomonas aeruginosa. They say it's reported at 95%. There have been a whole lot more cases of MRSA NOE, necrotizing otitis externa, reported over the last several years. Even Aspergillus has sort of seen an increase as well. And so this, again, sort of depends on your population health variables, but this is something that we see sort of classically and most commonly in the setting of diabetics with poor blood sugar control, but certainly kind of like acute invasive fungal sinus disease as well. This is something that there is a predilection for of immunocompromised patients as well. So again, the dynamics of the patient populations that you serve will sort of dictate the frequency in which we see it and the patient populations that you see it most. But in general, these are diabetic patients, okay? And so part of the management is that these diabetics need to get their blood sugar under control as part of the treatment strategy. Okay, so how do these patients present? They present with severe ear pain and otorrhea, so they have drainage from that painful ear. Now, interestingly, these patients are oftentimes afebrile, so you can't use that as a clinical discriminator to say, he doesn't have NOE. It's unreliable. One of the really ominous findings is a patient who presents with necrotizing otitis externa, and they also have cranial nerve palsies. That is a really big red flag. So whenever you get that history, those spidey senses really ought to be tingling. You need to be looking for skull-base osteomyelitis in those patients. So in terms of management, I mentioned this a moment ago. I'll say it again for those of you who may not be radiologists, ED docs, intensivists, whoever is watching this lecture. Keep in mind, a key component of their management is getting their glucose under control. In addition, they're going to get hit hard with antibiotics, both systemic, IV, PO potentially, and topical as well. They're going to be putting topical antibiotics into that external ear. But it's important to keep in mind that many of these patients will need surgical debridement, so this needs an ENT consult. So what do you look for? Well, you're looking for thickening and hyperenhancement of that EAC mucosa, that skin, that soft tissue lining the cartilaginous and bony external auditory canal. So here we can see the yellow arrow pointing to it, just how thickened and hyperenhancing that is. But that enhancing phlegmon and edema also extends into the surrounding soft tissues. So look in the preauricular, the periauricular, the auricular soft tissues for that matter. The external ear also gets involved with this. And because of the proximity to other critically important deep structures of the suprahyoid neck, you can have spread of infection to different spaces, and that includes the parotid, the masticator, and the parapharyngeal spaces extracranially, as well as intracranial spread of infection. And I can't stress enough, you have to be on the lookout for skull-base osteomyelitis in these patients. So look for that marrow edema. Here we can see on this T1 post-contrast fat-saturated sequence, this was not pneumatized mastoid on the CT, okay? Not entirely pneumatized mastoid. So we've got this abnormal enhancement and marrow replacement. That tells us we've got osteomyelitis going on. If you're using CT, use the bone findings as your friend. Look for those erosions. Those erosions can occur in the external auditory canal and the bony segment of it. You can have erosions of the mastoid and skull base as well. And also use your imaging findings. Again, CT, MRI, quite complementary here. Be on the lookout for abscess, something that's going to definitively make this a surgically managed case up front. So here's a case of necrotizing otitis externa. Look at the CT image, the axial non-contrast CT in bone algorithm reconstruction. We have all this soft tissue thickening within the external auditory canal. Look at that bone just a little bit lateral to the tip of the yellow arrow. We have the tiniest of erosions showing up. We have some other areas where the back wall of the TMJ is getting eroded. This can be tricky because you can have little bone fragments that are just normally sitting out lateral there. In this case, they were becoming eroded. If you look at the contralateral side, that's oftentimes, not perfect, but oftentimes a helper to see kind of how it should look in this patient. In this case, it's getting rarefied and eroded. Do an MRI. Here's our T1 pre-contrast imaging. We can see, right there, there's that little tiny cortical erosion. But the yellow arrow is also pointing toward all that soft tissue that's filling the external auditory canal and pooching out into the surrounding periauricular soft tissues denoted here by the red arrow. Give contrast, and you can see all this heterogeneously but fairly avidly enhancing infection throughout the EAC and the periauricular soft tissues. So again, MRI, CT, quite complementary when approaching necrotizing otitis externa. Usually these patients are coming to you from an emergency department setting, so it is quite appropriate to do the CT first. This is another time where it's totally fine to give contrast with the CT, so long as in addition to doing the bone reconstructions, you're also doing soft tissue recons. I like to do these, again, at a little bit thicker slices, maybe 2 millimeters. You're looking for complications and tip-offs for complications on the soft tissue. And so you want the high-res imaging of the bones and bone reconstruction to look for erosions. And if you're doing it with contrast, you should absolutely be asking for those soft tissue recons as well. If you don't have them, call the techs up, have them send them over. They can reconstruct those in the post-processing side of things. So again, stressing to you, CT and MRI, quite complementary in evaluating otitis externa. Next, we're going to move on to the inner ear, and sort of our hallmark lesion here is going to be labyrinthitis. So acute labyrinthitis, this is a subacute inflammatory or infectious process that involves the inner ear structures, typically subacute. Now, you certainly can have acute manifestations as well, but usually when it comes to imaging, we're kind of catching these with a little bit of lead time bias, and we're imaging more in the subacute phase. But this is infection or inflammation involving the membranous labyrinth that I talked about on the prior temporal bone anatomy lecture. So these patients may present with acute sensory neural hearing loss. That's a common presenting symptom. And again, this isn't something that's occurred over years. This is acute, rapid onset sensory neural hearing loss. It may be associated with vestibular symptoms as well. It sometimes is associated with tinnitus. And there's lots of etiologies. Oftentimes this is viral, but it can be bacterial. It can be seen in a setting of prior trauma, or we definitely see labyrinthitis in the post-surgical setting. If they do a translabyrinthine mastoidectomy, it's normal to have some labyrinthitis as part of the evolution of the surgical changes. And you can also have autoimmune etiologies as well. So here we can see sort of characteristic findings that you would see in the setting of acute labyrinthitis. This is an axial T1 post-contrast fat-saturated sequence. Can't stress enough, you need to saturate these post-contrast sequences. Okay, I don't fat saturate my pre-contrast T1s. I see a lot of people doing that. I don't think that's necessary. In fact, I think that obfuscates from what you want to see on the pre-contrast T1, which is your fat planes. But your post-contrast imaging, you really should be using fat saturation so that you can see what's enhancing. So as we look at our cochlea, we've got abnormal enhancement within all of the turns of the cochlea, albeit most significantly involving the basal turn. Look at the vestibule. What do we see? We see avid enhancement throughout the vestibule. Look at our semicircular canals as well. Those have avid enhancement within them. And even within our IAC, sort of tracking along the course of the vestibulocochlear and facial nerves within the IAC, we have abnormal enhancement. So classically, there hasn't really been any imaging in the setting of acute labyrinthitis. We just sort of say, give them some medicine for it, give them some steroids, maybe hit them with some antibiotics, potentially antiviral medication, but there was no role for imaging. And I think that's changing a lot. We're getting a lot more guidelines from the ENTs that especially these acute onset sensory neural hearing losses, it's worth doing an MRI because you want to try to catch it early. They may do more aggressive things like intratympanic medication delivery. So I think it's quite appropriate, in fact, now to be imaging these in the acute phase. So what do we look for? Well, it's important to keep in mind that as we approach these acute labyrinthitis images, on our T2 weighted imaging, we should have preserved fluid signal intensity within the membranous labyrinth. So as we look here at the semicircular canal, denoted on this axial T2 spaced image, this is the superior semicircular canal. We're sort of seeing the anterior and posterior limbs of it. We have preserved bright T2 signal intensity. What's it look like on the T1 weighted imaging? Well, it may be normal, or it may have increased T1 signal. And that increased T1 signal is usually due to the presence of intralabyrinthine hemorrhage, although it can also be from proteinaceous content, especially if there's something suppurative going on. So maintain T2 bright, ISO to hyperintense on T1 weighted imaging. Give contrast. Here we can see the post-contrast sequence. It may be mild to moderately enhancing, sort of in the acute phase. Now, there has been some buzz about this over the last probably 3 or 4 years of doing 3D FLAIR imaging both without and with contrast, because of the fact of the matter that FLAIR sequences have, of course, a T2 weighting, but they also have a component of T1 effects that go into them. And so it's sort of the proverbial turn it up to 11 on the amp. Whenever you give contrast, if you have pathology that's intrinsically has bright FLAIR signal, if it enhances, it may push it up just enough that it increases your conspicuity. Something we've been toying with, the 3D FLAIRs, I think mixed results at my shop so far, and that's something we're kind of working to try to optimize. Sometimes I think that the conventional fat-saturated spin echo type FLAIR acquisitions post-contrast show these findings better. So I haven't quite figured out how best to accomplish this. I know that a lot of places like the Mayo Clinic have been promoting this for a while, and I think it's not that it's not quite ready for prime time. I think it is a sequence we ought to be turning on and looking at in these acute labyrinthitis patients for sure. But I don't have great guidance on the best way to optimize it just yet. What does it look like on CT? Well, typically early on, it's going to be normal. However, if you have bacterial labyrinthitis, sort of the long-term complication that will oftentimes develop is labyrinthine ossificans, in which you have abnormal mineralization within the membranous labyrinth structures. The vestibule, the semicircular canals, the cochlea, any of those can be involved, although I typically see semicircular canal involvement most commonly, probably followed by cochlear second. Here's a few pearls, I think, when you're approaching these cases, because this is an area where the imaging has sensitivity but not great specificity. So you need to report the findings to the clinicians, and there's probably going to be some more workup and clinical correlation of the onset of symptoms and the presentation of the patient that will help figure out what the etiology is. That being said, if it's unilateral, that's typically favors a viral. Doesn't have to, it absolutely doesn't have to, but just someone who walks in off the street with these symptoms, if they have unilateral findings, it's still most commonly going to be viral. Particularly in children, although the same can be said for adults, but particularly in children because they're the most vulnerable patient population for this. If you have bilateral labyrinthitis, you do need to be strongly considering the fact that it's bacterial and it's meningogenic. So here was a child that, as you can see, has bilateral enhancement within the cochleas, the vestibules, as well as what we're seeing of portions of the semicircular canals. When you see that, make sure that you're looking at the brain. Here's the same child, coronal T1, post-contrast fat-saturated, raging meningitis. So look for that. The other thing that I think is a helpful pearl is use the T2 signal intensity within the labyrinth to differentiate from an intralabyrinthine schwannoma if it's segmental in terms of the enhancement, okay? So just to make sure that you're understanding what I'm saying, if you see segmental enhancement within the membranous labyrinth, particularly if it's in the basal turn of the cochlea, that's a very classic place to see it. Look at your T2 weighted imaging, your high-res, your T2 space, your KISS, your Fiesta, whatever you're using, and if there's a segmental filling defect there, be thinking about an intralabyrinthine schwannoma, because the infectious stuff tends not to have such a defined quote-unquote filling defect on the T2 weighted imaging. The other thing that I think can be helpful is look at the CT, because the other thing that gives you that T2 signal intensity dropout is mineralization. So if you have a patient that has some of that, and if they have chronic symptoms, look at the T-bone CT, make sure they don't have labyrinthine ossificans as well. So complementary imaging modalities, there's not a one-size-fits-all for these challenging cases. Next is the Petrous apex, and kind of our hallmark lesion here is apical petrusitis. So this is a localized infection of what is typically, not always, but typically a previously pneumatized Petrous apex. And that is typically due to spread of infection from the middle ear of the mastoid. And you can sort of think of this as being analogous to coalescent mastoiditis. These patients may present with the Gradinego syndrome. Certainly as you're preparing for boards and any standardized testing, this is a critically important thing to know all of the components of. Just know that in real life, They don't always present with a gratonegos, or they don't have a complete gratonegos, but it's still a very important thing to know about. And that includes features of acute otomastoiditis, facial pain along a trigeminal distribution, because you can see in this diagram next to that pus pocket within the petrous apex, we've got our trigeminal nerve right next to it. And then they may also have that lateral rectus palsy, because as you look just medial at sort of the tip of the petrous apex, that is where cranial nerve 6 runs through Dorello's canal, or the abducens canal, if you don't like to name things after people. So just keep in mind, gratonego syndrome, you do need to know what it is. Do know the 3 components: the acute otomastoiditis, the facial pain in a trigeminal distribution, and that lateral rectus palsy from abducens nerve irritation or injury. Just know that in real life, you typically don't get a complete gratonego. You may only have some of those components involved. What does it look like on imaging? Look for that rim-enhancing opacified petrous apex. You can see the yellow arrow pointing to it. We have fluid opacification with a thick rind of enhancement around it. We can also see that there are features of otomastoiditis. We do have enhancing fluid within the mastoid. Again, not a specific finding. You can get that just from chronic inflammation, but in someone who has features on imaging of apical petrositis, certainly this lends credence to this being an acute otomastoiditis. And if you do diffusion sequences, you may see reduced diffusivity within a mastoid, within a petrous apex abscess. You don't always get a true abscess there. Sometimes it's still more phlegmonous, but use the diffusion sequence. It doesn't necessarily rule out apical petrositis, but it definitely confers more specificity as to whether or not it's a true abscess that is formed. And you may also see enhancement of the cranial nerves as well on the post-contrast sequences. What do we look for on CT? We look for that trabecular breakdown, those cortical erosions. Again, this sounds an awful lot like acute coalescent otomastoiditis. It's sort of a translational skill set. You're just taking the imaging findings of one and moving it to another part of the mastoid. Simple as that, right? So here's a patient that had apical petrositis. This is another case that was lent to me by Dr. Seltman. Disregard the mastoidectomy changes that the patient has. Focus, you can see those there. Focus instead on the petrous apex. And it's eroded out. It's like sort of expanded and eroded out and irregular, and we've lost the bone stock along the posterior petrous ridge. Give contrast, and you can see that there's a thick rind of enhancement about it. Here's the T2 weighted imaging. You can see sort of this heterogeneous fluid within the petrous apex as well. Here was, again, looking at the T1 pre-contrast. You can see it's a little bit complex in terms of its signal intensity. And then there is just a little bit of sort of rim of enhancement forming along its back wall, but it hasn't really turned into a true thick rind of enhancement from an abscess. So I say this for a couple of reasons. First of all, to drive home the point that hopefully I've belabored enough in this lecture, is that CT and MRI are very much complementary when approaching these infections. But B, also to point out that you don't always get a true abscess forming. It's a spectrum of infection, okay? So don't wait until you have the abscess to call it. You need to get on the horn with their clinicians when you start seeing these features all lining up, because that's telling us that we have a process of infection that's forming. It's got aggressive features. It may not have completely loculated out as an abscess, and that's okay. They still need to know about it. These are all of these things that I'm talking about today. These are phone calls to the ordering docs. One of the important things to keep in mind is differentiating apical petrositis from trapped fluid within the petrous apex. This is something that I frequently get asked to do either overreads on from the outside world, or calling for clarification on reports that are read out on the brain MRIs from the ENTs, wanting to know if I think it's really apical petrositis. So I want to make sure that this is clear and everyone's on the same page. And the story here is told by the bones. You need to look at the bone changes on the temporal bone CT, because that really tells you what's going on. So patient on the left with apical petrositis, you can see opacified petrous apex, but the bone is indistinct. In fact, it's dehiscent. It's eroded out multifocally. That's not what just benign trapped fluid at the petrous apex does. We see benign trapped fluid in the petrous apex all the time. Literally, we see it every day. It looks differently. Take a look at the petrous apex trapped fluid. that cortex is preserved. It's sharp, it's distinct, we don't have dehiscence. And the other thing is it's not expansile. Sometimes that trapped fluid in the petrous apex gets T1 bright because it's sort of been there for a while and it's getting some protein content within it. And you're going to be tempted to say, is this a petrous apex cholesterol granuloma? The bones tell the story. Look for those expansile changes that tell you you're dealing with a cholesterol granuloma. In this case, the bones aren't expansile. We, in fact, have concave margins along the anterior petrous ridge here. It's not expansile. This is just trapped fluid. So let the bones tell the story. Don't confuse asymmetric petrous apex fluid as apical petrusitis. You need to look at the whole picture of what's going on because you don't want to send these patients to surgery unless you need to. Okay, so use the bones. All right, so the next infectious etiology that we're going to talk about is Bell palsy, and that's going to involve the intratemporal segment of the facial. So these patients will present with a peripheral facial nerve paralysis due to reactivation of the herpes simplex virus. That's sort of the catalyst here. And I do want to stress this is an image taken off of Wikipedia. This is not a patient of mine or of IU Health's. This is sort of open access on the internet. So thank you, Wikipedia, for providing this nice case of what this looks like. But this is due to the fact that this virus will lie dormant in the geniculate ganglion potentially for years or even decades before it rears its ugly head and reactivates. So what's the classic clinical presentation? These patients will have an acute onset of cranial nerve 7 dysfunction. It may be weakness, it may be a full-on flaccid palsy, but this typically escalates over about 1 to 2 days. And again, maybe facial weakness, maybe all-out paralysis. They may have lagophthalmos, this lid lag that you can see in this patient. And they can even have decreased taste in the anterior 2/3 of tongue because of the chorda tympani branch of the facial nerve that I talked about in the temporal bone anatomy lecture. They may not have all of these features, and that's fine, but they will have facial dysfunction. And again, it's critical to keep in mind this rapidly escalates over the course of, a day or two. It's not an acute onset, like bam, out of nowhere. That tells you maybe they've had a stroke, an infarct causing it. But it rapidly escalates over 1 to 2 days. And then it may sort of have a decrescendo phase in which the clinical symptoms recover over days to weeks, sometimes even a few months. What does it look like on imaging? Well, sort of the classic appearance is this neuritis appearance. And these patients will have this linear enhancement along the ipsilateral involved facial nerve segment. And it's been reported that they get this tuft-like enhancement at the fundus of the internal auditory canal that sort of extends up into the labyrinthine segment. They may also have asymmetric enhancement of the geniculate ganglion, kind of wrapping its way through the anterior tympanic segment. Now, less commonly, but not impossible, we do see it. You'll see enhancement or asymmetric increased enhancement along the mastoid and intraparotid segments of the cranial nerve as well. But here's the deal. Classic Bell palsy, they say rarely needs imaging. I'm not sure that's really true, and I think that probably the prudent thing is instead that they should get imaged, and they definitely need to get clinically followed up to resolution. So on imaging, we can see this sort of fundal enhancement, this tuft-like enhancement at the fundus of the IAC. See how it's located superiorly within the IAC? Kind of where we expect the facial nerve to be. Here we can also see this asymmetric enhancement of the tympanic segment of the facial nerve as well. So while traditionally anyway, classic Bell palsy, they say doesn't need to be imaged, I kind of disagree, but anytime you have atypical presentation of Bell's palsy, that always needs to get imaged because what you have to make sure that they don't have is perineural tumor spread. Other things that potentially could cause it would be a facial nerve schwannoma or a venous malformation or even Ramsay-Hunt syndrome. And there's been some publications suggesting that 3D FLAIR imaging may be quite helpful in that regard. So I think that probably a more prudent way to approach this is you can talk about the imaging findings, and if it has the right clinical setting, then you can suggest for sure that this is likely Bell palsy, but these have to get followed up. These have to get followed up clinically to resolution. And if they don't resolve, you can't call it Bell palsy, okay? This is a Larry Ginsbergism. You can only call it Bell palsy when the symptoms have resolved. I think he's probably right to a large degree. And yes, there's some bias if you work at a large cancer center where peritoneal tumor spread is so prevalent. But, the thing is, I have seen cases where, patients get referred to us for imaging of chronic Bell palsy. And sure enough, they have a big, nasty parotid tumor that's been living there for years and years. And now they have peritoneal tumor spread and the cat is out of the bag. So just exert great caution when it comes to Bell palsy, okay? If they have classic presentation, if they have classic imaging features, that's probably what it is. And recommend clinical follow-up to resolution with repeat short-term imaging if the symptoms do not resolve in an expected time course. If there is anything at all that is not typical about the clinical presentation, they absolutely have to get imaged. And I would recommend imaging all the way through the parotid glands as well, just to make sure they don't have a parotid tumor. All right, now we're going to move on to vascular temporal bone emergencies. And there's fewer, and so we'll go through these a little bit quicker. The first is to talk about internal carotid artery aneurysms. Fortunately, Petrous apex ICA aneurysms are quite rare lesions. They can be congenital, due usually at arising at the carotid-tympanic origin. You can also have acquired pseudoaneurysms in the setting of trauma or prior infection or even sometimes radiation. But how do these patients present? Well, it's a varied presentation. They can have sensorineural hearing loss. They may present with an outright stroke. They can have Horner syndrome due to the dissection of the carotid itself. They may oftentimes have pulsatile tinnitus. And in some very unfortunate cases, they may have profound otorrhea or epistaxis, depending on whether it's just sort of filling the middle ear itself or whether or not it's getting down the eustachian tube and coming out the nose. Well, fortunately, the imaging is quite good here. So it's reliably seen on imaging, and you're looking for dilatation of the ICA on CTA or MRA. I mean, that's kind of stuff that we look for already. So you know what it looks like. If you're doing conventional MRI that's non-vascular, these patients may have ovoid or fusiform masses, and it can be quite complex in terms of its wall signal characteristics. Oftentimes, you'll see areas of bright T1 signal due to blood products within the wall or the fake wall of this thing. You may also see heterogeneity and increased T1 signal intensity if there's clot within it as well. Look at the bone findings. I think that can be helpful. You want to look at the Petrous ICA canal, and sometimes that's enlarged. You can also, in chronic aneurysms or even pseudoaneurysms, get some curvilinear calcifications within the wall. I'd say that's for sure in a minority, but you can see those, and that can be a helpful tip-off as well. Now, fortunately, endovascular management is really the mainstay of therapy here, just because of the fact that you can put a stent or something across it, or maybe even a flow diverter across it as well. So less commonly do we see open surgeries for this particular segment of this particular segment of the internal carotid artery. But again, the challenge comes in recognizing these when they just sort of hit you in a weird way. That is to say, if they don't get a CTA or an MRA, you need to be aware of how bizarre these can sometimes appear. So this is a patient who came to the ER with a headache, and we have a non-contrast CT of the head, soft tissue. Pay attention to the skull base. Something's going on here. This is a classic SGO, right? We've got this soft tissue. It's at the skull base. It just doesn't look right. Don't think this is volume averaging through your muscles of mastication, your pterygoid there. So look at the bones. Oh, that's not normal. We sort of have this remodeled, sort of eroded out appearance of the skull base. So whenever you see something, exhaust the imaging that you have in order to figure out what it is. Okay, you want to know what this is. Use what you have at your disposal. So next we have our MRI to look at. Here's our T1 weighted image. And it's sort of this amorphous looking thing. Man, that looks like a mass. Maybe something that we need to put a needle in. Well, before you do that, use everything at your disposal. Here's our T2 weighted imaging. Whoa, this looks bizarre. So it's largely T2 dark, at least centrally, but man, it's got this very bizarre kind of lamellar appearance to the wall of it, alternating dark and bright lines. That should immediately have the old spidey senses tingling. Same kind of look on the FLAIR imaging. That stuff internally almost looks like a flow void, and that's what it is. This is a giant ICA pseudoaneurysm. You can see on the lateral DSA how this thing has that swirling filling within this. So don't biopsy this. Don't put a needle in everything that looks like a mass. Use the tools at your disposal. Make sure it's safe before you do anything crazy, okay? What you don't want to do is inadvertently put a needle into a vascular lesion like this. Next topic is the intratemporal facial nerve. And really one topic to discuss here is a facial nerve venous malformation. So you're saying to yourself, what in the hell is this guy talking about? How is this facial nerve venous malformation an emergency? We'll get to that in a minute. Well, first of all, a little backstory on these. These used to be called facial nerve hemangiomas. That's wrong. Bad. Don't use that terminology because it is just wrong. Okay, these are not hemangiomas. A hemangioma is a tumor. It is a vascular tumor, usually seen in kids, GLUT1 positive. That's not what these are. Instead, these are benign, congenital, low-flow vascular malformations. These are not tumors. So again, you're saying, great, I get that. Beat the dead horse. Talk about how these aren't tumors anymore. Fine. Why is this an emergency? Well, let's get to this. These are slow-growing lesions, right? It's a venous malformation. They've had them their whole life. But these can accelerate in terms of their growth during times of stress, during times of trauma, infection, and hormonal surges such as pregnancy. So whenever they rapidly grow, they're prone to bleed. And these things can, when they bleed, enlarge, and they can cause symptoms. So what do these look like? Well, most commonly we see these at the geniculate fossa. They can occur in the internal auditory canal along the course of the facial nerve, but I think those are quite rare. You'll see those on StatDX and other resources, and that's great. Be aware what they look like. I'll tell you, in real life, I have never once seen one in the IAC, and I've only seen a handful in the kind of the classic geniculate fossa location. But that's okay. Even though they're rare, you still need to know about them. So the geniculate fossa is more common. So how do these things present? Guess what? This is one of those atypical Bell palsy things where they have sort of maybe a slower progression of their facial weakness, or it's not resolving. They can also have this progressive sort of slow cranial nerve 7 paralysis. This usually occurs over weeks rather than that crescendo over 24 to 48 hours. Sometimes they'll even have hemifacial spasm or sensorineural hearing loss. These look like on imaging? Well, first of all, CT is still kind of the mainstay in terms of our workup. And you look for a lytic or a permeative expansile lesion at the typical places, including the geniculate ganglion, as well as in the IAC. But here's one at the geniculate ganglion. And they should have, in most cases, not all, but in most cases, look for that internal honeycomb type matrix or little spicules of bone. These are the same things that we see in the spine. They have sort of that corduroy or polka dot appearance. We always call those hemangiomas. We shouldn't. That's not what they are. But look for that kind of appearance in this location, and that is a facial nerve venous malformation. So here you can sort of get this little spiculated look to the bone changes internally within it. It's the expansile. It's even expanding out the labyrinthine segment of the facial nerve here, as well as the geniculate fossa. If we do an MRI, these will tend to be avidly enhancing. And here we look at our coronal T2 fat-saturated sequence, and you can see, yeah, it's kind of bright, just like a venous malformation should be. You may have some intrinsic dark T2 areas within it, those little spicules of bone. But circling back, why is this an emergent finding? Well, the reason is early surgery and cranial nerve 7 sparing surgery tend to have better outcomes in terms of getting their facial nerve function back. So this is emergent in the sense that you need to be able to recognize it. You need to be able to relay that information to the ENTs. That way they can do surgery sooner and hopefully spare more facial nerve function. That's why I still call this an emergency. It's an urgent phone call to them. Let them know what's going on. Let them know that this is not a tumor, and they will likely want to intervene on these patients sooner rather than later to prevent irreparable cranial nerve 7 injury. Another potential vascular temporal bone emergency is a dural AV fistula. This is an acquired direct shunt, typically from a dural artery to a dural venous sinus or an associated cortical vein. And the most common place that we see this, at least in this neighborhood, is the transverse sinus. So there's lots of etiologies. These are sometimes purely idiopathic. It can be post-traumatic and can be iatrogenic in etiology. But this is something that we see sort of as a pathologic response to venous thrombosis and occlusion. Okay, it's sort of this pathologic neoangiogenesis. You can sort of think it as organizing thrombus gone wild. And that's the setting that I think I see it probably most frequently in. Is this emergent? Because these can present upfront with hemorrhage, intracranial hemorrhage. Okay. What else do you look for in terms of findings? Because they don't always present with hemorrhage. In fact, only a minority do. One thing to look for is this network of transosseous collateralized channels. You can see just how sort of almost permeative and lytic the calvarium looks here along the backside of the temporal bone. That could easily get mistaked for osteomyelitis if you're not careful. So you need to be thinking, is this really permeative destructive bone changes, or are these enlarged transosseous venous channels, as in this case? Also, take a look at your adjacent sinuses. You want to look for thrombosis within that sinus that may have these internal wispy flow voids, or if you're doing time of flight MR angiography, look at this tortuous flow-related enhancement within that distal transverse and proximal sigmoid sinus. And you can even see sort of that flow-related enhancement within those transosseous venous channels as well. Compare that to the contralateral side where we see no flow because of those nulling pulses, the directional nulling pulses with time of flight MR angiography. We're not seeing veins elsewhere. Here we see this squiggly, almost arterialized neoangiogenesis within this previously thrombosed dural sinus. And I think that looking at the MIPS are sometimes nice in these, just to sort of give you that 30,000-foot overview, the lay of the land. I'll be perfectly honest, I don't think MIPS are all that useful in general. I use them certainly to check branch points of vessels, sort of as a last search pattern for looking for aneurysms and things. But here's an area where I think it is helpful, and you see that asymmetric, sort of irregular, tortuous flow within that abnormal dural sinus and those transosseous venous channels. And here we can see this sort of big outflowing vein. Really, angiography is definitive, not just for diagnosis, but also for treatment purposes, for endovascular management as well. All right, the last part of this talk is going to be the contextual temporal bone emergency. So there are several temporal bone lesions, and in fact, several normal anatomic variants that aren't emergencies in and of themselves, but in the appropriate context, these are critically urgent findings that need to get handed off to the surgeons. And this is typically in the preoperative planning setting. At my center, we end up getting a fair number of same-day stealth imaging sequences or volumetric sequences that the surgeons use for intraoperative guidance, or maybe they get them a day or two ahead of the surgery, but they oftentimes get them close to the surgery. And that is why you need to hand these findings off to them to make sure they know about it, to avoid any critical injuries or ramifications for the surgery. The other thing is sometimes some of these variants will mimic pathology as well. So I think that it's really important that you rapidly identify these and report them to the clinicians. I prefer to have direct communication, direct phone calls with them, because your goals as a radiologist, first of all, are to keep the patient safe. And you also want to keep the ENT or the neurosurgeon out of trouble. So these are important findings that you want to hand off to them. So there's lots of examples. I'm not going to go through all these for the sake of time, but I am going to select a handful of these to talk about just because I think they're quite important points to drive home. And the first will be the aberrant internal carotid artery. So this is one of those congenital lesions or congenital anomalies, if you will. And this is due to failed formation of your extracranial internal carotid artery. So we can see the image, sort of the inset image on the left, the normal state. Here is what happens in the aberrant internal carotid artery. You can see that we have our absent cervical segment. We can see that that is that is missing here with the dotted line representing where it typically would have been. And so in order to replace that, we have an exuberant growth and replacement via the ascending pharyngeal artery up to the inferior tympanic and then to the carotid-tympanic segment that you can see coursing through the T-bone. And that is what hooks into the horizontal Petrous ICA. I'll show you some more images of that here in a second, but just know that you have an absent cervical ICA, and that's replaced via the ascending pharyngeal to inferior tympanic to carotid-tympanic before it junctions back in with the horizontal Petrous ICA. This is important because this is a surgical landmine that you do not want to send the patient into surgery without being reported, okay? The other thing is, on imaging, this is not a glomus tympanicum. If you get the history of a red retrotympanic mass, it is incumbent upon you as the radiologist to decipher whether or not that is a true mass sitting on the cochlear promontory or whether you have an aberrant internal carotid artery. So what does it look like? Well, we have an artery that courses along the cochlear promontory. On this axial CTA, you can see we should not have a vessel sitting on the cochlear promontory. We do here. And again, your primary job as the radiologist here is to say this is an aberrant ICA and this is not a glomus tympanicum paraganglioma. One will get resected. One you want to stay the hell away from, okay? So it is critical that you make that distinction. And so how do we do this? We trace this vessel back. We go south and we find this enlarged inferior tympanic canaliculus, denoted here by the red arrow. As we work our way downstream, we can see this stenotic junction where it joins back in with the horizontal Petrous internal carotid artery segment. That is critical. That is your number one job, is to say this is an artery and this is not a mass. The patient's life may depend on that. This is associated, they say, about a third of the time with the persistent stapedial artery as well. But the bottom line here is this is a don't touch lesion. Unfortunately, this is one that certainly injured during surgery, so look for blood within the middle ear as well. Next is our jugular bulb dehiscence. This is another normal anatomic variant. And so in this case, you can see this jugular bulb sort of protruding into the middle ear via a dehiscent jugular plate. So almost like this, I don't know, like this slug or something that's sort of poking its head up into the middle ear. This is something that you want to make sure the ENT surgeons know about. There are some reports that this may be associated with an increased risk of tinnitus and hearing loss and maybe Meniere's disease. It may be completely asymptomatic, and my guess is probably most of the time it is. On otoscopy, these should present with a sort of blue retrotympanic mass, so that's a good tip-off that you're dealing with jugular bulb dehiscence. Whenever you see that, or whenever the ENT sees that, they may refer the patient to you for vascular imaging, and so CTA or MRA or MRV is usually confirmatory. This also is a surgical risk. Okay, you want to let the surgeons know about this. Here we can see that defect. We have just a little bit of the vessel pooching out in the middle ear, and here we can see that there's some blood products within the middle ear as well. So less critical if this gets injured, but still you don't want bleeding into that uncontrolled space or difficult to control space. So you want to let them know about this ahead of time due to the surgical risk. One other thing that I think is a big setup for potential surgical risk is the aberrant facial nerve core. I talked about this in the conductive hearing loss. I think I talked about this in the temporal bone anatomy lecture. Guess what? You're going to get it a third time because this is just that critical. So just to sort of give you a lay of how things should be, in case you haven't watched the T-bone anatomy lecture yet, the tympanic segment of the facial nerve usually courses just below the lateral semicircular canal as it's moving through the middle ear cavity. But in some congenital anomalies, that cranial nerve 7 course gets malpositioned. So this is seen in the setting of oval window atresia. That's sort of the big association. You can also see this in congenital external and middle ear malformations. So EAC atresias, be looking for it. And so this is a patient that had sort of a complex external and middle ear malformation. You can see they've got membranous atresia of the external auditory canal. They have sort of a smallish middle ear cavity. There's sort of this really ugly, rudimentary ossicular fusion mass. In addition, they also have a congenitally absent lateral semicircular canal. So they also, in this case, in a syndromic case, have some inner ear malformations. But take a look at this facial nerve course. That's sitting too inferior and too medial. In fact, it's overlying this atresia plate. So you want to point that out to the surgeons. You want to let them know, hey, facial nerve is sitting right over the atresia plate. If you go in to do an ossicular reconstruction to bring back their hearing, this is an increased risk of facial nerve injury. You want them to have that information ahead of time so they can make an informed decision about how to proceed. It may not preclude them from doing surgery, but you want them to know about it ahead of time. That is not a tripwire that you want them to stumble upon. And here again, you can see that we have that that membranous atresia of the EAC denoted by this kind of magenta arrow. So again, stressing this, it's critical. It is absolutely critical for the patient that you identify the course of cranial nerve 7 prior to middle ear surgery, especially in those cases where it has an aberrant course like this. Then the last thing I'm going to talk about in these contextual T-bone emergencies is a temporal bone cephalus. And this is simply a protrusion of the intracranial contents into the middle ear mastoid via a Tegman defect. So here we see this broad Tegman defect. We have a pacified mastoid down deep to it. Before you go and say this is fluid from a CSF leak or just some localized fluid within the mastoid, use what's at your disposal. Take a look at all of the sequences. Here is our T2 weighted image. You can see we actually have brain herniating through this defect. So this is sort of a meningoencephalocele going on here. And these can be congenital. They may be acquired. There is thought to be an association of these acquired ones with intracranial hypertension. So this is definitely something that I keep on my search pattern when I'm reporting those cases as well. Sort of one of those constellation findings that ups my suspicion that I'm dealing with intracranial hypertension when I see it. These patients do have an increased risk of meningitis for obvious reasons, especially if it communicates to the external atmosphere, and for also obvious reasons, depending on what part of the brain is protruding through, these patients may also be at increased risk of seizures as well. But this is just a critical thing that you want to identify and point out to the surgeons before they do middle ear and mastoid surgery, because the last thing they want to do is get in there and realize they've got a hunk of brain that's herniating down, which is going to make it a more difficult surgery and something they potentially are going to have to work in concert with neurosurgery for repair. Okay, so that was sort of a whirlwind overview of some non-traumatic. Well, as always, thanks for tuning in to this next in a series of full-length lectures. For those of you that are impacted by COVID-19, hang in there. It's tough. I think it's going to get a lot tougher over the next coming days and weeks. Try to stay positive, stay safe, stay healthy, take care of friends, take care of loved ones, take care of each other. Thanks again.